really appreciate the professors coming here. Welcome to the stage, renowned Australian epidemiologist, Professor Mike Toole, winner of the Order of Australia Medal, if I'm not mistaken. And would you say hello? And I'll just check that the audience can hear you.
Yep. Hi, Gabe, and all the listeners.
How's that, Ned?
Loud and clear.
Beautiful. Prof, you've had an extraordinary career in communicable disease control, public health in emergency settings and other things. Can you tell us a little bit about some of the highlights of your career so the audience knows something about you?
Sure. Well, believe it or not, I've been working in low and middle income countries for almost 50 years. I lived in Thailand for 8 years. I lived in Somalia for 2 years. I've lived in West Africa, in a small country called Togo. Then I spent 10 years at the US Centers for Disease Control. And for most of that time, I was coordinating the US government response to public health emergencies overseas, almost always linked to conflict. So I worked in Bosnia, in Somalia, in Rwanda, a number of other conflict zones, and refugees and food emergencies. I came back to Australia more than 20 years ago, and I've worked with the HIV pandemic. I've worked a lot on the polio, on the elimination program, or the eradication program. When I was working with refugees, I had to deal with a lot of epidemics or outbreaks of communicable diseases, including measles, malaria, tuberculosis, hepatitis, meningitis, and most recent polio, of course, and most recently Ebola in the country of Guinea in West Africa.
Thanks, Prof. I'd like to start bringing people up shortly, so get ready and put your hands up if you've got a new question. We've got some people who we already know want to ask questions, and I've prepared them to come up. If I may just indulge, if everyone might indulge me, I've got a couple of questions that are more locally based. We've got a zero COVID strategy so far in Australia. We came there haltingly last year. I think you'll probably agree. They initially wanted a hard suppression strategy. That's not possible with such an infectious disease, clearly. Can you, well, I'll get straight to the punch and you can tell me if I'm putting too fine a point on it. What explains the sheer incompetence and arrogance of the New South Wales state and federal governments? Is it primarily big business driving their refusal to adhere to the precautionary principle?
I wouldn't use those adjectives, but all the same, New South Wales is the outlier in terms of outbreak response compared with all the other states and territories. So unfortunately this year we've seen a series of outbreaks in every capital city, every state capital city, and one territory capital city, Darwin. So other than New South Wales, all of those states have gone in very quickly and hard. They've introduced quite strong restrictions after 2 or 3 days of reporting a new cluster of cases. And they've all come out of those lockdowns quite quickly, usually within 2 weeks. New South Wales took a different approach. They have always said that they would take a different approach. And I think they initially thought that they could control the outbreak in Sydney through contact tracing and testing and isolating. That proved to be very difficult with the Delta strain, which is much more infectious. And we saw early on in the outbreak in Sydney, infections occurring in public places through what's been called fleeting contact. Some of those were caught on CCTV. People were walking past each other in a large department store and the transmission occurring. And then it soon got out of control. Restrictions were brought in on day 9 of the outbreak in Sydney, compared with the most recent lockdown in Melbourne, which was introduced on the lockdown was introduced on day 3. Victoria's still not completely controlling this outbreak, but the number of cases, we had 8 today. compared with New South Wales reported 262 new cases. And there I don't look at daily numbers because they will jump around. But the 7-day average in Sydney, or now New South Wales, because it's spread out of Sydney, is up to 222. And it keeps going up every day. And I think the current strategy of vaccinating themselves out of this outbreak is not realistic. It's just not going to work because we're starting from such a low bar of 20% of adults fully vaccinated, that to reach what is now the government's goal, the federal government's goal of 70%, will take several months. And I don't think we can afford to let that outbreak continue to grow for several months, because it will inevitably reach thousands of cases a day, hundreds of hospitalizations, and sadly, many deaths.
Does it frustrate you to know that this was completely preventable through not having quarantine, that you could drive a limo through, and through having lockdown early? We could have done a 2-week lockdown and been done with this, and we're going to be locked down for months now. Does that frustrate you?
It's extremely frustrating, Gabe. I have been writing and talking about the need to improve the quarantine system for a very long time. Ever since last year, when a breach of hotel quarantine in Melbourne led to an outbreak that reached more than 600 cases a day. More than 700 people died during that outbreak, and 98% of cases could be traced back to that original leak in hotel quarantine. Now, since then, that state, Victoria, has learned the lesson, I think, from that terrible experience. And so have some other states like South Australia and to some degree West Australia. And so what they've done to improve the quality of hotel quarantine is to thoroughly review the ventilation in every single room of every single hotel where returning travellers stay. And if there've been problems, then they've rectified those problems with ventilation engineers, occupational hygienists, making sure each room has what we call negative pressure. So when a guest opens the door to the corridor, the air goes into their room, which is exactly what you want. Unfortunately, we've seen a lot of cases where there's been positive pressure. So when that guest opened, an infected guest, opened their door to say pick up their meal or drop off their laundry, the virus is spread out into the corridor, and another guest has opened their door soon after or at the same time and got infected. Now, 2 states have not fixed that problem, and that's New South Wales and Queensland. They just won't do it. And also, those 2 states don't require that their frontline staff wear respiratory masks, often called N95 masks, which the other states do. And so what we have at the moment is a very precarious situation where the virus keeps entering the country. And because it's Delta, when it escapes, it spreads very fast. And we've seen how fast that's happening in Sydney. So obviously there's only one gold standard quarantine system, and that's just outside Darwin at a place called Howard Springs, which is single-story cabins, separate air conditioning systems, a veranda where you can sit in the open air, and best of all, the staff, when they're delivering meals or picking up laundry, walk through the open air. They don't walk down these corridors, which have become almost petri dishes for the virus in city hotels. Now, the best solution, of course, would be to build a Howard Springs-like facility in all 5 states, mainland states. But the government has not moved on that except in Victoria, which means the virus can still enter the country until those 2 states fix their systems. It's become so common to have these quarantine leaks that the media hardly reports on them anymore. They've been occurring since mid-November on average every 8 days. We can't continue to cope with a leak every 8 days. Not all of them lead to community outbreaks, but many of them do. The example in Sydney, of course, was not hotel quarantine. It was the lack of oversight of the airport transport system. So you had this situation where a subcontractor drove a limousine for flight crew, did not wear a mask, and was not vaccinated. So he caught the virus, spread it to his wife, and then the rest is history. So that system of contracting and subcontracting was heavily condemned by a judicial inquiry in Victoria last year, and it's not done anymore in Victoria. There is a single employer of all quarantine staff in Victoria. It's called, what's it called? VCQ, Victorian COVID Quarantine. They employ all staff, they train all staff, they supervise them and monitor compliance. That system does not exist in either New South Wales or Queensland. They rely heavily still on private security guards, a practice that was heavily condemned in Victoria this time last year.
We could, thank you, Prof. We could go down many rabbit holes about the Australian situation. So I'm just going to ask a final one that might be slightly more relevant to people in the room. Then we go to some audience questions. We can circle back because I've got so many questions for you, but probably won't get to them all. I'm obviously furious about the situation. No doubt you are too. I, in fact, had to, for my own sanity, had to go on a news fast because it just upsets me too much to know how completely avoidable all of this was. We don't need to be in lockdown now. It sounds like you too.
Yes,
yeah.
I turn off the TV after the New South Wales press conference.
I don't watch the press conference.
Sometimes I can't watch that either.
I can't watch it anymore. Yeah. So I guess the question for me is practical. It's practical about Australia, and hopefully this is relevant, and then we'll get to audience questions. Has the New South Wales government now introduced COVID into Australia permanently? What do you think practically, given the politics up here in Macquarie, I'm in Woolloomooloo, so I'm pointing at Macquarie Street. What do you think that, the practicality of what's going to happen? How is this going to play out, or is it endemic? And then I guess my subsequent question, as it relates to on a personal level, I've got 2 AstraZenecas in me. I did 10.5 weeks apart because of the outbreak. So for fully vaccinated people, what precautions should we be taking in Sydney when they start opening up, or if they start opening up? So both questions, if you could, Prof.
Well, the first question requires a crystal ball. I sold mine on eBay because it wasn't proving to be very reliable. It could become endemic unless much stronger measures are taken in New South Wales. It's already spreading to regional cities like Newcastle. It's inevitable that it will spread to others because the restrictions are just not harsh enough. For example, there's no enforcement of the advice that people in Greater Sydney should not leave the greater metropolitan area. That is not being enforced. And so we have now this cluster in Newcastle. That was a very important measure in Victoria last year to protect both the regional centres of our state, but also to protect the rest of the country. And I think it's quite irresponsible not to have those measures in place. And it doesn't look like the Premier has any intention to introduce that. Now, within the Greater Sydney area, the Premier tells us every day that New South Wales has the harshest restrictions ever imposed in Australia, which is patently false. The restrictions within the 8 LGAs that are most affected are similar, but not the same as Victoria's what we call stage 4 restrictions. They don't include a night curfew. Now, there's argument about the whether there really is an epidemiological impact of the night curfew. But having gone through that for several months last year, my own observation was that it made the job of enforcement by the police so much easier. So, at the moment in those 8 LGAs, you can't leave, You can't go more than 5 kilometres. But enforcing that's very difficult. You have to put up checkpoints, stop every car, check their driver's license to see if they're more than 5 k's from home. When you have a curfew, there's hardly any cars on the road, and the police can just very easily stop every car. And there were only 2 reasons to leave your home after 8 p.m. And they were medical emergencies, easy to verify, and essential work. And we have a system where you get an online work travel permit. So very easy for the police to check. So I think that is worth considering in Sydney. I know there'll be a lot of libertarians will oppose it. We got through it. I slept much better because there was no traffic noise. It was so quiet. The other thing is I think the current restrictions in those 8 LGAs should be extended to the whole metropolitan area. I mean our modelling team at the Burnet Institute, have seen in the last few days that there are parts of Sydney outside those 8 LGAs that actually have higher infection rates than some of those 8 LGAs. They include Bayside, a couple of others I can't remember. So it is, it's inevitable they're going to have to add 8 LGAs. Why not just do it across Sydney? You can't go more than 5 kilometres from your home for any other reason than essential work and medical emergencies. Everywhere in Sydney, there will be a supermarket or a food shop or a pet store within 5 k's. I'm pretty sure of that.
That's for the same reason they've dragged their feet all year, which is we don't know exactly why, but they do what they do on Macquarie Street. And the last question that I asked you was for someone like myself, and this is a personal question, but hopefully it'll influence some people in the audience and it'll be relevant to overseas listeners because there's a lot of people around the world listening, is, I'm fully vaccinated. So, I was hoping to get the Novavax before we went from zero COVID. That's what I was hoping for.
Yes, so was I.
Got it. So
I've had 2 doses of AstraZeneca, 12 weeks apart.
Well, good for you. I've got slightly less protection because I had a week.
It's okay.
It's okay. So my parents are getting to their 2nd doses as well. Most of my family has had Pfizer or AstraZeneca. We've got a couple of holdouts, but we're getting to them. The question, I guess, is, realistically, and this is relevant now that Delta's surging around the world, so it's relevant to a lot of people. What risks are worth taking if they do open up? I mean, again, it's a fairly low case right now. So would you, if you were me, go to the local cafe and pick up a takeaway coffee? How cautious would you be regarding things like long COVID, for example, at this point, given my situation?
Well, as I think that the US has just discovered that the advice the CDC gave back in May that vaccinated people did not have to wear a mask indoors was premature. They've now backed off that. And they're now suggesting that people wear masks when they leave their home in those counties where the case rate is over a certain threshold. That's most of the US now. Except for pockets in the Northeast, the virus is rampaging across the US. So my first advice to you is to wear a mask outdoors, even if you're in Woolloomooloo. We've seen very recently in Melbourne transmissions that occurred at 2 different sports stadiums. One was people were watching a rugby game, and the other they were watching an Australian rules game. People who were sitting outdoors, 3 rows away from an infected person, they never left their seat. One was a 12-year-old boy. So of course he didn't go to the bar at halftime. He didn't go to the toilet. He sat there for the whole game and got infected. So I think Sydney should look at that and say, yes, particularly in your case, queuing up at the takeaway. That's madness not to wear a mask because, you're supposed to socially distance, but this Delta virus, and in fact, the previous strains also, can be spread through the air further than the 1.5 meters, which your cafe probably has a mark on the footpath. So wear a mask outdoors. That should be the rule right across the Greater Sydney metropolitan area. we've heard some news today about the spread at a beach party near Newcastle, where I can bet no one was wearing a mask. Well, I'm in Melbourne, where we wear masks everywhere, like we outdoors, indoors. As soon as we leave the home, we put on a mask, don't take it off until we get back home, except when we're driving. I see these scenes from, example, Shelley Beach and Manly, of these huge groups of young people sitting on the sand, shouting and singing and laughing and not wearing a mask and not socially distancing. So I think that's an easy thing to do. That's easy for me to say as a Melburnian, because we've been wearing masks forever. But surely Sydneysiders can get used to it. It's not difficult, as you know. You just showed me a photo of your mask. So that was the other measure I would introduce. As for the vaccine,
Professor Toole, sorry, before you move on, could you talk a little bit about the relative protection provided by different types of masks, from a bandana up to a surgical mask, up to a KN95, up to an N95? What would you recommend?
Well, it's been clear for some time now that scarves and bandanas do not offer enough protection. It goes well below 50% reduction in transmission. Then you get to cloth masks. That probably their efficacy depends first on how well they fit your face. They need to fit quite tightly, and of course they need to be washed every day. Then you go to the disposable masks. They're reasonably good, but I know that's what I wear. And I know I've sometimes got to adjust the mask over my nose, and then my glasses fog up. But I think they are about 70 to 80% effective. Then you get to respiratory masks. And the reason one brand is called an N95 is they offer 95% reduction. Now that's almost as good as a vaccine, but of course you've got to do it every day. Whereas a vaccine, once you've had your 2 doses, you're fine. I've now lost my train of thought. What was I talking about? Masks. Yeah, that's about it. So forget bandanas and scarves, not nearly effective enough. And they are not permitted in Melbourne under the current rules that you have to wear a mask outdoors and indoors. They have to be cloth or disposable. People are not expected to wear N95 masks out in the community because we need them for healthcare workers and quarantine workers.
Well, people have heard enough from me. So we've got, just to remind people, we've got renowned epidemiologist, Professor Mike Toole from the Burnet Institute here with us now. And we're going to take questions from...
Can I just complete my answer about...
Of course, Professor, please. Before you do, may I just ask, I've got a few people like Naomi earlier and Isabella and the other people who spoke before who wanted their questions answered. Just put your hand up and we'll try and get to you. And anyone else who's got a question, start putting your hand up. What, Ned?
Yeah, I'll handle the Q, Gabe. You can focus on just continuing the interview.
No problem. I'll forward you my summary of those questions then. Yeah, please go ahead.
Just quickly, when you had your first shot of AstraZeneca during a Delta outbreak in Sydney, the reduction in your ability to transmit, or actually to get infected and then transmitted, was only reduced by 33%. Actually, it offered 33% protection, not very much. However, that one dose provided you with 70% protection against hospitalization, ICU, and death. When you got your second dose, it went up to 83% protection against any symptomatic infection, 87% protection against hospitalization and being in an ICU, and 92% protection from death. So the second dose makes a huge difference.
Which vaccine is this? I missed
AstraZeneca.
And the protection against infection, sorry, can you remind me?
33%. It's the same with Pfizer.
After the second dose even?
Oh, no, sorry. One dose, 33% protection from both vaccines, Pfizer and AstraZeneca. When you go up to 2 doses, it becomes 83% for Pfizer, 61% for AstraZeneca. That's for any infection. But against hospitalization, it's 86, 87% for both vaccines, ICU the same, and protection against death the same. So the big difference is the protection against infection, 83% Pfizer, 61% with AstraZeneca.
That's why we want our Novavaxes, but okay, we'll have.
No one's got Novavax yet. I don't know what the delay is, but I've heard there are manufacturing problems.
Okay, Ned, I feel like Naomi might have been first in the queue. Ned, do you want me to call on people once you've brought them up? Is that okay?
Yeah, and
Okay.
As people ask their questions, we'll rotate people off the stage to keep it manageable. But thanks to everybody for asking questions. Professor, this is absolutely fascinating. So we really genuinely appreciate you being here.
Indeed. I'm going to remind people that we are recording this portion of the day. So please, if you're not comfortable with that, we may have lost someone who is not comfortable with being recorded. So I'm not sure if she is. I was going to call on you first, but if you are comfortable being recorded, please stay on stage and ask your question. So that was important to say. Naomi, let's keep the questions as brief as possible, but Naomi, you had 3 questions, if you could.
Thanks. Hi, Professor Sassoon. My question was, is there a way to measure the risk of the potential long-term side effects of a vaccination versus COVID lasting and mutating in society for a longer period of time, so over the next 4 or 5 years? Is there a possibility that it will then mutate to a point where 80% of the population that is relatively safe from COVID now will then, come under risk? That's.
Could I answer one question at a time?
Okay, hold it, Naomi. Yep.
We don't know of any long-term side effects of any vaccine at the moment. The side effects we're aware of course, are with the so-called adenovirus vaccines, the AstraZeneca and Johnson & Johnson. And we know now, we've got a lot of data on it, particularly from Europe, of this acute blood clotting event, which the abbreviation is TTS. It's a very unusual form of clotting event because it's accompanied by a drastic reduction in platelets. It's like this clotting uses up all the platelets, but people that know about these things think there's some unusual, unexpected immune response that destroys the platelets. Now so that occurs so I'm using the AstraZeneca example around, sorry, I had this written down. It's about 1 in 50,000 in people over 50 and 1 in 35,000 in under 50s. Now, doctors have got much better at diagnosing and treating this condition. So at the moment, the risk of death in any age group is about 1 in a million. Now, that's a very low risk compared with the risk of dying. Based on the Australian experience, up till now, 1 in every 35 people who got infected has died. That's changing a bit because most of those deaths were in older age groups, and increasingly those age groups are vaccinated, so they're protected. But 1 in 35 is a very different level of risk than the 1 in a million risk of a blood clotting event or dying of a blood clotting event. Now, the long-term effectiveness of the vaccines is still up in the air, both in terms of protecting people from the Delta variant and earlier strains of the virus. It seems like immunity lasts pretty well up until 6 months but we're really early in the rollout. So we just have to wait and see how much longer that antibody level stays adequate for protection. The other problem, of course, is new variants. And one of the dangers of the current situation, where many wealthy countries are reaching quite high vaccination levels, with the exception of Australia, but in the continent of Africa, for example, has vaccinated just 4% of their population. And cases are rising rapidly, more rapidly than ever in Africa since the beginning of this pandemic, as are deaths and hospitalizations. Now, if we allow that situation to continue, cases will get out of control. And the more transmission there is, the more likely that there'll be a new mutation that may be worse than Delta, both in terms of infectiousness and its ability to avoid the immune response induced by a vaccine. So that's really the nightmare that I have. But this virus, like any virus, mutates randomly. As it replicates, it makes what we call copying errors. So it just makes mistakes. Most of those mistakes lead to a mutant version that is of no advantage to the virus. So it just disappears. It dies away. 4 times so far, the mutation has led to an advantage. So we had the alpha, beta, gamma, and now delta. And delta is the most infectious. If a new variant emerges that is even more infectious than Delta, I think we're in deep trouble everywhere in the world.
Naomi, what was your second question?
Thank you. My second question was, are we going to be able to vaccinate everyone? Because to my understanding, vaccination only works if we do it quickly. And I live in India, and there aren't enough vaccines. And so I wonder, and as you pointed out, places in Africa only been vaccinated up to 4%. So vaccine hesitancy aside, so even if everyone was ready to get vaccinated tomorrow, do we actually have enough vaccines to ensure that everybody gets vaccinated within the next few months? And if that doesn't happen, which it doesn't look like it's going to happen now this year, then what is the efficacy of even those that are vaccinated, are they really protected?
Well, to start with the last bit, there are currently 14 vaccines licensed in at least one country. 9 of those have published data in well-renowned peer-reviewed journals. So we can really estimate, and increasingly they are publishing the efficacy of their vaccines against Delta. So those vaccines are Pfizer, Moderna, Johnson & Johnson, AstraZeneca, Gamaleya, which is often called Sputnik 5, Sinopharm, which is produced in China, Coronavac, which is also produced in China, and Covaxin, which is produced in India by the Burnet biotech company. Now, all those vaccines have, in the real world, so not talking about clinical trials, real world have very high efficacy against severe disease. Their efficacy or effectiveness against infection varies with the Delta strain. I mean, it varies from, I just quoted Pfizer at 87% protection against hospitalization with the Delta strain. And the others are more or less similar. A recent study in Argentina found that the Coronavac vaccine, or often known as Sinovac, was highly effective against hospitalizations, not as effective against infection. The Gamaleya vaccine from Russia, more than 90% effective against Delta in Bahrain, or the UAE, actually, United Arab Emirates. So at the moment with Delta, the protection is very high. For your first part of that question, can we vaccinate the world? In theory, we could, but at the current rate, we can't. At the latest estimate by the IMF is that people across the world won't be fully vaccinated until mid-2023 or even late 2023. For the reasons I gave earlier, we can't allow that to happen. So there are a number of ways that we can increase vaccine equity. The US is starting to share their vaccine reserves. So they've promised to share 500 million doses in the coming months, and they're already ramping it up. They're doing that under the banner of COVAX, the Global Vaccination Facility, which is great. That's really good. And I think President Biden yesterday summed it up when a journalist asked him, why are we doing this? Why are we giving vaccines away? He said, we're doing it to save lives and end the pandemic. That's it. Well done, Joe. Another way, of course, is to increase manufacture of the vaccines. And the best way to do that would be for the vaccine companies to share their intellectual property and the technology required to actually produce the vaccines, which can be quite complicated. And they should do that under a voluntary marketing agreements. We know India, for example, has the highest capacity in the world to produce vaccines, but also a lot of other countries, South Africa, the Philippines, Indonesia, Singapore, Vietnam. So I think sharing that intellectual property, the patents and the technology would be very helpful. Because a country like India could churn out hundreds of millions of doses of any vaccine once they have that information on how to manufacture, say, Pfizer or Moderna, or eventually Novavax. The other thing, of course, is for rich countries to increase their contributions to COVAX, their financial contributions. But at the current rate, the answer to your question is no, we can't vaccinate the world before perhaps the end of 2023. So we need action urgently.
I know Naomi had a final question, but maybe you could table that and we'll hold off on it momentarily. It's an interesting one, but let's try and get to a couple more people at least. Martina, you had a very specific question.
Hello, thank you for being here and discussing such an important topic. I know that situation right now is dire. Hello?
Yep, sorry, there might be a bit of feedback. Apologies. I don't know what's going on.
No problem. Yeah, I know that right now the situation is dire and that big time lockdown is needed. But for the future, maybe, what do you think about sort of utilizing smart, specific, data-driven, localized lockdowns that would prevent the spread of infection and then maybe would employ predicting the infection rates in community by surveilling wastewater for SARS-CoV-2 virus? There is some research out there that suggests that trends in SARS-CoV-2 concentration precede the trends in clinical COVID positive cases by up to 2 weeks. And this could be additionally combined with sort of tracking the efficacy of vaccination efforts in localized regions. Is there any effort on that side, maybe for the future?
Just starting with wastewater surveillance, this is done routinely in Australia, and it often does predict clusters of cases. And we had an example today. So in a city outside of Sydney called Newcastle, a couple of days ago, the viral fragments were detected in the wastewater. And so there was an alert put out, and the government asked people in that city to get tested. And today we found out there were 5 cases in that city. So yes, it's an excellent tool in surveillance. I think another one is asymptomatic surveillance, often called sentinel surveillance of high-risk workplaces. Obviously, airports are and ports are very important because you have people coming in and out of, from many countries. And you may know that not the current outbreak in Singapore, but the previous outbreak in Singapore was caused by fully vaccinated airport workers being infected by a returning traveller and then going to the food court in that airport and spreading it across the community. So doing routine asymptomatic, that's testing people who don't have symptoms in, say, airports, maybe meat works that are known to be very high risk, perhaps teachers would be also excellent. Now, when can we get to a place where we can, when can we rely on smarter measures than whole city lockdowns? I don't think we're there yet, because the big unanswered question is, at what level of population vaccination coverage will we reach what's been called herd immunity, so that overall, not just the vaccinated, but the unvaccinated are protected from transmission? No country in the world has reached that yet. Many people, including Dr. Anthony Fauci, believe it will be 80% of the whole population, not the adult population. So we have a challenge. We can't vaccinate kids under 12 yet. I think by the end of the year, we will be able to do that. Then we have vaccine hesitancy, which in the US is going up. It's around 25% of adult Americans either definitely won't or probably won't get vaccinated. So when you add those two figures, the percent of children in the population and the vaccine hesitant, we can't mathematically reach 80%. Well, the US can't. And you can see, even with the high, more than 50% coverage in the US, 60% coverage in the UK and Israel, 70% coverage in Malta, they're still having outbreaks. So we don't yet know at what percentage we can then ease restrictions, have what you call smart lockdowns, localized. We don't know that level yet. But I suspect Dr. Fauci will be correct and that it will be 80% plus, and no country has reached that yet.
Nathan, hopefully that answered Martina's question. Nathan, I think you might have had a question about ivermectin.
Yeah, I mean, so many questions come to mind. Thank you for your time, by the way. This has been interesting and great. But yeah, I think some people, such as myself, have kind of been a little turned off at the way. I don't like the term vaccine hesitancy. I like the term vaccine skepticism, because it just kind of implies that, yeah, this is whatever we want to think. This is a relatively untested in the grand scheme of, like, these things are supposed to take 15 years technology, and it is a giant experiment, like it or not, and maybe the benefits outweigh the cost, but it is an experiment. And whether a multi-pronged approach to reaching herd immunity would be advisable. And it seems like a lot of the kind of expert class or administrative bodies, regulatory bodies, seem to just kind of be poo-pooing this ivermectin thing, which is promising in a few small studies, but kind of overwhelmingly promising to the point where, as a prophylactic agent, where it would be preventative, very cheap, has a long-term safety profile, and although they are relatively small and they're not the randomized, double-blind controlled, gold standard trials that you'd hope for, because there's not a lot of money behind them and not a lot of profit motive to justify such a expenditure. Some of the more, don't want to say conspiratorial, but there is a kind of question about whether there's some sort of regulatory body capture that's gone on, where, because these things whether it's possible, for example, the financial crash of 2008 was kind of brought on by regulatory bodies that were too connected to the industry they were designed to regulate, and whether this has happened to big pharma, which, as everyone knows, is one of the most profitable industries in the world in human history. And so I guess the question is, are we not looking closely enough at potential cheap, safe remedies at the to, you know, kind of, it seems like vaccine or bust kind of mentality right now. And rather than saying, when they see these amazing ivermectin results in small studies, rather than saying, oh, they're small studies, they're not randomized control trial, they should say, yeah, well, let's do randomized control trials and see what happens, you know, rather than just going full steam ahead with this single pronged approach to reaching herd immunity. So if you could talk to that, I mean, the one
Nathan, can you finish the question?
Yeah, sorry. I mean, this Argentinian study is just kind of mind blowing, where they gave it to 1,200 people that were working in hospitals, and the whole control group.
Sorry, it's hard to follow specifically. I think we have the gist of your questions. Probably details from a specific study are not going to be additive. But Professor, hopefully you got that question about ivermectin and trust in the system and incentives. So Nathan, thank you for the question.
Yes, thank you. No regulatory body in the world, including the very big ones like European Medicines Agency and the Food and Drug Administration, have approved ivermectin for treatment of COVID. And the main reason is not skepticism on their part. The company that makes ivermectin has not applied for authorization. The company itself does not yet, is not yet satisfied that it is effective. You mentioned a couple of small trials have looked promising. There's been no one randomized controlled trial, but a review paper early this year found that there was no evidence that there was a benefit from ivermectin. So I think it's like all of these cases, you don't approve a drug if the manufacturer doesn't apply for authorization, and they haven't done so. And the first question about vaccines usually take 50 years technology is not quite true, but of course it is true for the malaria vaccine, which we still don't have. But most vaccines take about 10 years to basically come up with the formula for the vaccine and then do randomized controlled trials. Now, often those randomized controlled trials take place in a context where there aren't that many cases. So to get your required sample size to show whether, you know, giving that drug or not giving that drug or that vaccine makes a difference often requires many years, such as the meningitis vaccine. Now with COVID, we had a totally unprecedented situation. We've reported more than 200 million cases in 18 months. So there was so many cases occurring that it took a very short time to prove whether the vaccine was preventing COVID or not. We've never been in that situation before. And yes, there was a lot of money going into that. It's understandable. We haven't had a pandemic like this in our lifetimes. So I would not mistrust the vaccine just because it was developed quickly.
Okay, thank you. Ned, did you have anything to add before we went to Will?
No. Hopefully that was a helpful answer for all the Brett Weinstein fans out there. Will, good to have you back on stage. Feel free to jump in here.
Hey, Dr. Toole, thanks for taking a little bit of time to talk. So just a quick question for you. I, like a lot of people who work on the policy side, we're really struggling to try to make really good decisions by looking at all the lagging indicators that we have access to. And I'm curious if in your work or research or in any of your network, you've come across any leading indicators that we can watch that might help us to anchor things a little bit quicker than what we have to work with?
It's a good question. And of course, our knowledge keeps growing as the pandemic goes on. Just to remind you that, you know, in April 2020, masks were not recommended for the public. almost anywhere in the world. Of course, in Asia, people were accustomed to wearing masks when there was an illness spreading. But in the rest of the world, we were very slow. It wasn't until around about sometime early this year that the US CDC and the World Health Organization recognized that airborne transmission through fine particles that we call aerosols was an important part of the spread of this virus. So we keep learning. Now, was your question referring to what are the leading indicators during an outbreak to kind of relax restrictions, or was it a broader question? If you might clarify it, please.
Yeah, Dr. Toole, it is both a broader question, but also just a check-in to your intuition. So if there's anything interesting that comes to mind as you hear the question, I'd love to hear.
Okay, well, let's stick to an outbreak, because that's what we're living through in Australia, or at least in Sydney. I think there's two really important indicators, other than the raw numbers each day. And of course, the raw numbers need to be converted to 7-day averages to monitor trends. But the two important indicators that I would be tracking would be each day, what was the proportion of the new cases that were linked to a known source of infection? Now, you want to get that up to 100%. If you've still got a large number of new cases that you don't know the origin of the transmission, that means there could be undetected chains of transmission out in the community, maybe mostly among young people and mostly asymptomatic. So that's one. The other is the proportion of new cases that have been isolating at home and not out in the community. That's a very important one. Of course, that won't prevent transmission within that household, but it will keep, and by the way, the Delta variant spreads very quickly within households. It tends, if one person gets infected, everyone gets infected. But keeping them at home and not out in the community while they're infectious is extremely important. So they're the two indicators that I watch every day, rather than focusing just on the raw numbers.
Thank you very much, Doctor.
Thanks, Will. We've got Scott on stage. Scott, how are you doing? What do you got to ask?
Hi, thank you. Well, I'm in San Diego, and like most of the country, we're sending the kids back to school in the coming weeks. And of course, the kids under 12 are not yet eligible for the vaccine, and different parts of the country are using different protocols. And I'm wondering, what do we know about the risks for kids as far as getting infected or transmitting to others? It seems like it's hard to find that information, and whether there is a difference with the younger kids versus the adults. Thank you.
Yes, schools are a big challenge. My philosophy has been that when there's an outbreak and you're considering restrictions, closing schools should ideally be the last thing you do. And when you ease restrictions, ideally opening schools should be the first thing you do, because we've now got a cohort of students that are missing out on their face-to-face experience of education. I think this is really concerning for the future of that cohort. Now, I think there are three ways that you can make schools safer. First, vaccinate all teachers. Make sure all teachers are fully vaccinated. And my opinion is that should be mandatory. I know there will be resistance to that in some states. I imagine in California, it might be very different from, say, Louisiana. But so vaccinate all children. Make sure all children over 12 are wearing masks whenever they're near each other. Stagger drop-off and pick-up times by parents. We all know how parents gather outside the school gates and gossip and laugh and stuff. Control that. Finally, of course, we can't do that yet. Oh, sorry, I missed one step. Pay attention to ventilation within schools. Bring in experts to look at, say, those common corridors with the lockers and the gym and other parts of the school. If there are windows, open them. Of course, that's difficult when in the winter, but the more fresh air that's been circulating in schools, the less likely there's going to be a transmission event. It's when kids are in a poorly ventilated indoor space and maybe singing in a choir or shouting, cheering a basketball team, that's when the virus spreads. And because the last thing is, eventually we need to vaccinate all children. And I know the main vaccine manufacturers are doing trials on children as young as 6 months of age. Hopefully, and I am hopeful by the end of 2021, that we will be able to vaccinate children. And we should not be hesitant about that if there's supply. Now in Australia, we have a huge problem because we don't have enough vaccine to vaccinate everyone. So we started with the vulnerable, the elderly, frontline workers, but now we're shifting to the 20 to 40-year-old age group. Because they're active, they often are doing essential work that can't stop during an outbreak. I think children will be next, although I should mention, I've already said, teachers should be treated as a high priority group. So there's no magic formula, but I think the CDC does have quite good guidelines for opening schools in the US, and they will evolve over time with more experience. But here in a different city, Brisbane at the moment is experiencing an outbreak that is almost all primary school children and a couple of their teachers and of course parents, but it's basically spreading in 6 schools. Most new cases are under the age of 9. They probably won't have severe disease, but it seems like they're just as likely to suffer from long COVID, which at the moment, it seems to occur between 10 and 30% of COVID patients. It varies by the study.
Thanks for the question, Scott. A reminder, we're here with leading epidemiologist Michael Toole, winner of the Order of Australian Medal and board member at the Burnet Institute in Melbourne. He's being very generous with his time. You'll have to be insistent if you must leave us, but we've got quite a few more questions, so you'll have to let me know.
Probably 2 o'clock. I'm getting hungry.
So me too. I'll give you a 10-minute lead time indicator and we'll see if we can still ask some more questions. We're recording this session for anyone, full disclosure, I've said this before, so you consent to the recording. And Naomi, Kevin, Madan, Isabella, Omar, you should put your hands up because we haven't forgotten you. Dr. Ziad's on stage. He's a friend of ours in Western Sydney. He's be very interested in hearing what he has to ask and offer.
Good afternoon, Professor Toole. My name is Ziad. I'm one of the doctors in Sydney. We're in the middle of the big Delta outbreak. Is it true that we will still be going through much less infections once we vaccinate around the 75 to 80% mark? And what sort of numbers that we should be expecting if we get to that 80% mark within Australia? I know that the context is Australian, but I live here, so just wanted to learn about it a bit more. Thank you.
Thank you, Dr. Ziad. As you probably know, there's been quite a lot of different modelling in Australia looking at what level of vaccine coverage could allow us to gradually, well, first of all, allow more travellers to return to Australia and also to have fewer harsh restrictions like lockdowns. Now, the modelling by the Doherty Institute is the one that's guiding the federal government's sort of roadmap out of the pandemic. And they estimate that at 70% of adults vaccinated, that you could have fewer lockdowns. They didn't say no lockdowns, but fewer lockdowns without wildfire spread of the virus, and that you could bring back the cap on international arrivals back to where it was several months ago. It's currently at 50%. Then the real critical one was the 80%. So at 80%, they expected that you could rarely have lockdowns and have a level of hospitalizations and deaths that would be no more than during the average flu season. So they're the figures that the government is following. Now, my own institute, the Burnet Institute, also did modelling. We used a different methodology, but we found that to safely open up Australia, we needed to get to 90% of over 60s vaccinated and at least 70% of under 60s. So it averages out at about 80%, so very similar, really. But in the meantime, you can't, you're in Sydney, mathematically you cannot vaccinate yourself out of this outbreak. It has to be a vaccine plus strategy because it's just going to take too long in Sydney to get that higher, an adequately high vaccine coverage. Keep in mind, both the vaccines require 6 weeks minimum between doses. So even if you vaccinated 500,000 people a week, by the end of August, which is your government's goal to ease restrictions, you'd have 2 million people who'd got their first dose. And as I said earlier, first doses of either vaccine only lead to a protection of 33%. So that's not going to stop the outbreak, but it will reduce hospitalizations.
Yeah, this is Gabe. I think they're desperate, and I think it's a total schmozzle. But Dr. Ziad, I think, might have a different view, and I'm going to give Dr. Ziad the opportunity to ask. I mean, I think you're more sanguine about the present situation in New South Wales than Professor Toole.
No, not sanguine. Professor Toole obviously has the numbers and the master of numbers. What I'm saying is there's no way that the lockdowns, that's my view, lockdowns are not there to get us out of the pandemic. Lockdowns are temporary measures that you use to control and reduce death and the transmission of infection. But in an area like Sydney, I don't think lockdowns would get us on its own out of it. So I think a combination of lockdown, like the professor said, like a combination of lockdowns and a massive drive of vaccination can potentially lead to reduced death, which reduce hospitalization and death, and that's the main concern. And if that drive continues and we can get to 80%, which numbers-wise it potentially can happen by November, then that might get us out of it, but not on its own. I definitely agree with the professor. I think they've done a horrible job at the start, but they thought they can control the Delta like they've done with the Alpha, but that's a different beast. I think the Delta is the John Wick of variants. Dr.
Z, I didn't mean to put you on the spot. I asked you the question recently, and I've asked the professor the question, although I'm not sure if you directly answered, Prof. 2 AstraZeneca shots, right? If it was okay, you answered me about the cafes, but if it was okay for me to go and visit my parents, for example, and they'd had 1 shot, right? How safe is that? I mean, my question, I guess, is more about long-term COVID, because I don't think I'm going to be put in the hospital, right? I suspect that I'm concerned about the unknown effects, and no one's asked yet about long-haul COVID. Can you speak to what our situation, being double Astra, would be?
Yeah, often there's, I think, too much emphasis on reducing deaths and ignoring the long COVID. And, I've read study after study of long COVID. These are really debilitating symptoms that these people suffer from. and they don't really depend on age, and they don't depend on the severity of the initial illness. So people had very mild, there's a study of outpatients in Geneva. So these people were treated in outpatients, they never needed hospitalization. And they're finding 20 to 30% of those patients still have symptoms up to 6 months. This is the University of Geneva Hospital. And fatigue, breathlessness, a lot of neurological symptoms. Now, so, we don't want to expose, say, school children, students, or anyone for that matter, to that kind of situation. Now, the percentage in Sydney has been lower. It's been 12%. That's patients followed up from St Vincent's Hospital in Sydney. But not all COVID patients were treated at that hospital. It's a subsample. But even 12% is high. So yes, the vaccine and the other precautions are both necessary. And Dr. Ziad, I think fully vaccinating 80% of adults in Sydney by November is very optimistic.
I agree, very, very optimistic. I'm trying to look at the light.
Yeah.
All right, I'd love to jump in here and just ask a question of you, Professor Toole. And I'm going to steelman a point of view I hear from a lot of people on here doing these rooms, especially in the United States, where we have our stubborn sense of rugged individualism. We are freedom lovers, you might have heard. And so, common refrain: mask requirements, school closures, restaurant closures, vaccine mandates, all noble given the circumstances, but coming with a cost, an encroachment on freedom. They extract an economic and a psychic toll. And COVID's going to be endemic for the next few years, decades, maybe permanently, no matter what we do. And so is the risk-averse direction definitely the better way to go? Should we lower speed limits to cut down on traffic fatalities for the same reason? And what expertise should we have to make these judgments, given that these issues touch not just on medicine and epidemiology, but also on politics and psychology and economics and so many other fields?
Sure. Well, just reducing speed limits did work. It did lead to a reduction in road accidents and deaths, as did limiting the amount of alcohol that you could drink when you drove. Now, they're both, some people would say, infringements on personal freedoms, but I think they're both in the interests of the individuals and for society at large. There are an increasing number of studies coming out that have been published in peer-reviewed journals like The Lancet that show the economic impact of lockdowns is actually less than the economic impact on countries that were very reluctant to impose lockdowns and waited too long until they had very disruptive outbreaks. And we've seen that in the UK, in the US, and Brazil are the three main examples of that. So their economies have suffered worse than those countries like Australia, New Zealand, Vietnam, Malaysia, that did employ lockdowns very quickly. I suppose, the best example is China. China's economy over the last 12 months has been doing extremely well. And that's in part because whenever they detect a cluster of cases, they lock down. They're doing it right now in Nanjing, in Wuhan, in parts of Shanghai, Beijing, and they test everybody. Now, we can't all do that. Last week, the authorities in Nanjing tested 9 million people. I don't think any of the rest of the world can do that. But in terms of their lockdown policy, it's basically kept their economy humming along probably better than any other advanced economy.
Hey, that is cool if I could ask the professor a few questions.
Yeah, well, let's focus on your topmost question first, because the professor likes to go one at a time. We're here with leading epidemiologist, Professor Mike Toole from the Burnet Institute. We've got him for another 17 minutes. So pick your top question, Harlan. Welcome to the stage.
Thank you. And it's funny because it's actually related to the question that you just previously asked. First off, I want to ask, how are you doing, Professor Mike Toole? Nice to meet you.
Likewise.
I wanted to ask, so I actually live in New York City, so the vaccine is being mandated here up to the point where, you know, if you're unvaccinated, you cannot partake in society at this point, or when the rules will be enforced, that will be the case. I got an email from one of my previous employers. I still get emails from them, but they sent out an email saying that before in the city, if you worked for any health industry, you had to get the vaccine, or either you had to get weekly COVID-19 tests. Now, because 2 days ago, the mayor has announced that, you know, vaccine mandates are a thing, private employers are now, I guess you could say, cracking down. And on the email, it said that if you do not have the vaccine, you can no longer work there. So at this point, I believe that, you know, people are pretty much the arms are being bent to take this vaccine. I want to ask if you get any adverse side effects or any long-term side effects, you know, because I believe we're still fairly into, you know, this vaccine. Who will be liable for any damages health-wise that you get? Will that be solely on you, or will people be able to hold other people accountable? Because I honestly feel that, you know, at this point, you know, people will have the issue of choosing between putting food on their table or taking a vaccine that they're not 100% too sure they want to take. And you know, the clock is ticking for certain individuals.
Great question, Harlan. Thank you.
Yeah, this question will be increasingly debated in every country in the world. It's being debated in Australia, even though we're far from you know, high levels of vaccination. I've noticed what's been happening in the US. President Biden mandating vaccination for public servants, and if they refuse, they have to get weekly testing. I'm against blanket mandatory vaccinations, so forcing everyone to get vaccinated. It's just not an effective public health measure. It makes people angry. But I am in favor of people being vaccinated having certain privileges that the unvaccinated won't have. And one personal example is that prior to the pandemic, I lived part-time in Cairo, Egypt. And I'm just really badly want to go back to my home in Cairo, but I can't at the moment. But once I am allowed to travel, I am fully vaccinated. I do not want to share a plane with anyone who's not vaccinated. And of course, if I was a flight attendant, I would also have the same opinion. You know? So I think allowing people who are vaccinated to travel on planes, but not allowing the unvaccinated, they make a choice not to get vaccinated. And I think they need to expect there'll be certain restrictions. Now, you asked about who will be responsible. That's an excellent question. If a workplace makes it mandatory to get the vaccine, I think they need to indemnify themselves so they can do that through their insurance. And I think they need to state very clearly to the employees that if by a very small chance there is a serious side effect, and I gave the figures before, for under 50s, it's 1 in 35,000. But in terms of deaths, it's 1 in 1 million. So very large employers like Walmart might in fact have some of their employees get these clotting events, except they don't give us AstraZeneca. They could get them from Johnson & Johnson. So they would then have to cover any expenses involved. This is my opinion. In any employee having serious side effects from a vaccine. This will vary from jurisdiction to jurisdiction. In Australia, for example, our family doctors are indemnified by the government for giving vaccines. So they cannot be sued. Family doctors cannot be sued because a patient they vaccinated got side effects. The government will step in.
And briefly, because we've got 3 people still waiting to ask questions and only 11 minutes left, I think you sort of answered my practical question earlier. If the local government here in New South Wales lets me visit people or a friend or family, if they're double vaccinated and I'm double vaccinated, should be fine, right? Yeah.
Should be.
Yeah. Okay. I'm still worried about that long COVID, Professor. Yeah, Ned, sorry, you were going to say.
I just said I told Harlan we could ask one more very brief question, and then Professor, if you wouldn't mind just giving a relatively quick answer, and then we'll move on to the other 3 folks and get you out of here at the top of the hour. Go ahead, Harlan.
Thank you again for your time, Professor, and sorry to keep you. Do you believe that people being stigmatized because they choose to be critical thinkers of, getting this vaccine or not, is something that is highly possible? Me being a former football player, I see that now the NFL players are now being told that they have to wear bracelets to differentiate which players have the vaccine and which don't. I'm feeling like, this could be very problematic as people are now giving up their health information because industries are telling them to do so. Do you feel that people that are not choosing to get the vaccine and being called anti-vaxxers or being blamed for people's deaths is something that could be very, very, very possible because of these mandates? Right? And do you think it's worth it? Do you think people should be labeled and should be stigmatized until everybody gets vaccinated?
Thank you. I think this is a question more for a human rights expert. Of course, any form of stigmatization for whatever reason is undesirable. And I'm surprised about this bracelet thing. I'm not quite sure why they're doing that and what will be the reaction by the vaccinated to the unvaccinated proposal. Look, the country that's had the longest experience with these vaccine certificates, they call them a green pass, is Israel. And they have found, so if you are not vaccinated, you can't go to a cinema, you can't go to a concert, you can't go to a gym, and there are a number of other venues that you can't go to. And they have found, since they introduced that, a big uptick in vaccinations among young people, because young people who most want to go to those events and want to go to the gym, they want to go to the cinema, they want to go to a concert. So it has had a positive effect. Now, people are not getting vaccinated. I think of those, a minority are anti-vaxxers. I think most are what we call hesitant for a range of reasons. Fear of the side effects. A lot of people worry, as one of the previous participants said, that the vaccines were developed too quickly. Others are just taking a wait and see attitude. Let's see how this goes and then I'll get around to it. The problem with the anti-vaxxers, some of them, is that they're spreading so much misinformation on social media. So they are a very dangerous group. Now, lumping in the others, the hesitants, in with the anti-vaxxers is kind of unfair. And they certainly shouldn't be subject to the same level of stigmatization. It's going to be very tricky. As we move through this pandemic, I think we're going to realize that really vaccination is our only way out. So if some people choose, and they have the right to choose, not to participate in that movement, I think inevitably they will have fewer options in their lives.
Yeah, we don't have much time. Thanks, Prof. I think we've been really cautious on Clubhouse over the last few weeks to differentiate strongly between anti-vaxxers and vaccine hesitant people. I try and make that distinction at every opportunity. We're recording this session. We've got the final 7 minutes with Professor Mike Toole. Madan, let's keep the questions and the answers brief, hopefully. Go ahead.
Okay, thank you, Dr. Toole, for being here. We appreciate it. And my question is, as an epidemiologist, what do you think of the lack of transparency on the part of both China and WHO, which might have probably helped us prepare for this pandemic battle better? Thank you.
Well, hindsight is always 2020. I think one of the problems early on, let's focus on the World Health Organization, was they had their hands tied, really. And that's due to what are called the 2005 International Health Regulations that were endorsed by every member nation on Earth, including the United States and Australia. Now, they had a lot of positive features of them, but one of the negative ones was that under those regulations, the headquarters of WHO could not announce an outbreak of a disease in a member nation and then impose those regulations on that country unless they had got the okay from that country. And in this case, it was China. And that was slow in coming. They were only 2 weeks late in announcing a public health emergency of international importance. But that 2 weeks was critical. For example, that's when the virus spread through Italy or northern Italy. So I think those international health regulations have to be amended so that the WHO can act more independently. Under what I just said, the international health regulations, headquarters had no authority to send an investigation team into China, none whatsoever. So I think that has to be changed. As for China itself, I can't really comment on cover-ups. I think we all know that in the first few weeks, there were doctors in Wuhan that were alarmed and they were silenced. And no one can endorse that. But how deep that cover-up goes and for how long, I can't comment. And I must say, now, whenever there's a new case in China, they announce it straight away to the world because they know they can't get away with hiding it. And suddenly there'll be a whole lot of people turning up at a hospital with COVID and the journalists will find out. So now they're very quick in announcing that. So I trust their figures at the moment.
Thank you so much for having me on the stage. Doc, my name is Marilyn, and I have a question because I wasn't able to find it anywhere.
Keep it brief, Marilyn. We've only got 3 or 4 minutes left. We've only got 3 or 4 minutes left with the professor, so keep it very, very brief, please.
Yeah, no problem. And so with the new Delta variant, how are they able to test for it? Because they were saying the PCR is not an effective method to test for the new variant.
Thanks, Marilyn.
Yes, so you're correct. The PCR tests detects whether there is a coronavirus. You're infected. Okay, it will not say what kind of virus. So in countries like the US, Australia, the UK, and most of Europe, they have a system where they send a sample of those positive tests to a special laboratory where they do what's called genome sequencing. And so they identify what variant it is. So in the US, for example, they have a system and they've ramped it up over the last 6 months. When they announced, the CDC recently announced that 83% of new cases in the US are the Delta variant. That wasn't based on all the tests they did. That was based on a sample from every state and territory in the US. And they track every state. So, the Delta variant first raced through Missouri. Missouri was the first, then Alabama, then Louisiana, Mississippi, Florida. So they can pinpoint where the Delta variant is dominant. I hope that answered your question.
Yeah, I think thank you, Prof. I think we may not have time for the final question unless you're okay with it. You're okay? No, okay. So Prof has to go. I'm sorry, Courtney, we didn't get to you. I want to thank you so much, Professor, for your time. Ned, before we final thank you, do you have any final quick words? Because we've got 2 minutes left, 1.5.
No, I'm sure I speak on behalf of most, if not all, the people in the room. We're just really grateful you take the time to speak with us, and we really appreciate you, Professor. Thank you. Professor, if I may say, we've been really effective in bringing experts like you on, and we're so thankful that you've been so generous with your time. And just so you know, we receive direct messages from people saying that it's really helped them, it's comforted them, it's also been helpful to them in deciding to get vaccinated. So we've actually had people message us and say so. So thank you so much for your time, Prof.
Okay, thanks. Go.
Bon appetit.
Ned, merci.